To understand the modern realities of clinical safety, we have to start with the physical definition of an invasive procedure. It is any medical action that enters the body, punctures the skin, or inserts instruments. Look at this historical baseline chart. In the 1980s, less than 20% of all surgeries in the United States took place outside of a highly regulated hospital operating room. By 2023, that metric inverted. 60% of all U.S. surgeries are now performed in outpatient settings. That percentage translates to 2.4 million office-based procedures happening every single year inside primary care facilities. We are talking about routine biopsies, incisions and drainage, and minor excisions. The physical geography of medical care has moved into local clinics, but the biological stakes of breaking the human skin remain the same. The mechanical reality of surgery is unchanged. We have simply decentralized where the scalpel is used, exposing a massive new population of patients to clinical risk. This geographic transition amplifies a specific cognitive bias, the minor surgery fallacy. Labeling a procedure as minor subconsciously signals to medical staff that the threat level is low, naturally dropping the guard of the entire room. But human biology does not recognize the word minor. The moment the skin barrier is breached, the patient becomes vulnerable to infection, bleeding, and sudden physiological complications. These patients are facing those physiological threats while lying on a standard examination table, separate from traditional operating room infrastructure. Unlike tertiary hospital staff who drill surgical safety protocols daily, general primary care teams rarely receive highly specific OR-level perioperative training. Combining high patient vulnerability with a lack of specialized surgical training creates a scenario where routine settings may struggle to manage sudden, high-stakes complications. Calling it a minor procedure does not neutralize the biological threat. It simply removes the systemic safety nets designed to catch clinical errors. To understand why those safety nets disappear, we have to look objectively at how primary healthcare facilities are engineered. This chart maps the distinct tiers of medical care. The primary tier is the first point of contact, prioritizing rapid preventative care, diagnostics, and high turnover. This contrasts with secondary and tertiary facilities, built for deliberate interventions and highly specialized treatment. When you force a surgical procedure into an environment built for speed and broad screening, you trigger 5 severe systemic points of friction. First, acute limitations in resources. Clinics rarely have dedicated perioperative staff or highly specialized surgical instruments available. Second, the patient population is highly variable. Walk-in clinic patients present with entirely unknown baseline risks. Third, time management. General practitioners operate under extreme scheduling pressures, allocating only minutes per patient. Fourth, there is a total absence of immediate surgical specialty backup. Finally, critical communication barriers naturally form when teams rush. Primary care clinics are built for breadth and momentum. That makes their standard operating environment inherently hostile to the slow, methodical safety checks required for safe surgery. Operating under these 5 constraints, we have to ask a precise diagnostic question. Where exactly does the system fail the patient? The clinical data tracking adverse events in outpatient surgery provides a very clear answer. Look at a standard procedure timeline. Severe injuries are rarely caused by physical errors during the cutting phase. Instead, data shows 1 in 3 adverse events in outpatient settings is directly attributable to inadequate patient assessment before the procedure even begins. The extreme volume and time pressures of the clinic physically compress the crucial window where a doctor should be evaluating the patient's medical history and current physiological state. This is rarely a lapse in individual clinical skill. It is the predictable statistical failure of an unstandardized workflow running too fast. The greatest physiological danger in outpatient surgery manifests long before the scalpel is lifted. Protecting the patient requires a rigid, systemic intervention specifically targeting that pre-assessment phase. To neutralize that specific failure rate, clinical engineers rely on the Gaher EGCAP safety standards. These standards enforce a highly structured, 4-phase procedural timeline explicitly designed for the outpatient environment. To address the primary vulnerability, the framework aggressively targets Phase 1 with standard CIP.02. SIP-02 mandates a documented physician assessment to identify medical risk factors, accompanied by an independent nursing assessment and confirmation of completed patient investigations. This standard functions as an artificial brake. It forces a deliberate, mandatory pause in the momentum of a fast-paced clinic, ensuring no risk factor is overlooked in the rush. Once the assessment is cleared, the system requires one final safety check before the first incision, outlined in standard SIP.03. SIP.03 requires the surgery site be visibly marked by the physician. Crucially, the patient or family must verbally confirm this correct site. GEHAR SIP-02 and 03 function as clinical pillars that construct an invisible OR-level safety buffer inside a standard clinic room. So, does introducing this rigid friction into a high-speed primary care clinic actually change patient outcomes? The clinical data detailing the consistent application of structured frameworks and the WHO Surgical Safety Checklist provides the answer. By enforcing the pre-procedure pause, clinics achieve a 36% reduction in major surgical complications. Furthermore, that exact same procedural discipline yields a 40% reduction in surgical site infections. For clinical managers and facility directors, quality standards must be viewed through this lens. They are the single highest leverage clinical tools available to protect patient lives. As surgical volume continues its massive migration away from traditional hospitals, enforcing these specific frameworks is the only scalable method to manage the accompanying risk. Standardizing the pre-procedure pause is the ultimate mechanical defense. It allows the primary care system to safely absorb the reality of the outpatient shift.